My name is Michael, and I've spent over half my life as a paramedic in ambulances and airboats, aircraft, and oil rigs, providing care in just about every environment imaginable. Now, I'm a respiratory therapist on a hospital children's transport team, and with the lung volumes, I want to help you to become better and more comfortable with respiratory care and ventilation for patients of all ages. Hey everybody, welcome to Volume 1 of the Lung Volumes. And today we're going to talk about clinically relevant anatomy and physiology. Now before you get discouraged, this is not the A&P that you had to sit through before. This is a discussion about the stuff that I think got left out or gets glossed over or we kind of forget about that really matters to respiratory care. And this is stuff that you really need to think about when you're putting somebody on a ventilator, when you're administering oxygen or doing things like that. And believe it or not, it's probably stuff that you're using already every single day and you just don't think about it. So we're going to talk about all that stuff that matters. Our objectives for today: discussion of upper airway anatomy. Now again, before you get discouraged, this is not basic upper airway anatomy. We're going to relate this to how we provide respiratory care and why that's important to all of your patients. We're going to talk about something I almost guarantee was left out of paramedic or nursing program, and that was the mechanism of heat and moisture exchange and why that is so important and why we need to be thinking really, really hard about providing humidity even to some of our least critical patients and some of our patients in our shortest transports. We're going to talk about the diaphragm probably in a way you haven't thought about before and why replacing all the functions of the diaphragm are important, not just the inspiratory side. And we're going to go back to the difference between oxygenation, ventilation, and respiration and provide examples of each of those so we can think about what we're doing with our ventilator, with our bag mask, with our supplemental oxygen every single time. So first I want to talk about the nervous system. And when we think about reasons why people get intubated, we think about things like respiratory failure, ARDS, pneumonia, stuff like that. A lot of the reasons that we intubate folks in the acute care and the pre-hospital and in the critical care transport setting, is not so much a problem with their lungs. A lot of times it's the problem with their head or their central nervous system. And so if we look here at this drawing, the two yellow lines there are the phrenic nerves. And why the phrenic nerves are important is because they innervate the diaphragm. They will make the diaphragm go up and down, either voluntarily or involuntarily. And some of the times when people, the way I think about it is forget to breathe, is something is wrong or interrupted with their diaphragm innervation. Those impulses can't get there. The phrenic nerves exit the diaphragm somewhere between C3 and C5 and on both sides. And so if somebody has a high cervical fracture or anywhere above C3 or C5, then the chance that they're going to have interrupted respiratory function is really, really high. Also, if they have some kind of stroke on that side, some kind of unilateral neck trauma, anything like that can cause them to have a single-sided innervation of the diaphragm where you get this paradoxical breathing but with no chest trauma. And that can confuse people sometimes. But this particular part of the anatomy is really, really important to think about as you're doing your full body assessment and wondering why your patient isn't breathing or isn't breathing adequately. Speaking of the diaphragm, and everybody knows you don't get out of EMT school without learning about the diaphragm, what the diaphragm does, and how it works. And we always learn that the diaphragm is the muscle of inspiration. It contracts downward. When it contracts downward, it increases the intrathoracic space, decreasing intrathoracic pressure, causing a pressure gradient from the outside air inside, causing you to inhale. Everybody knows that. Oftentimes what is left out of that discussion, though, is the expiratory function of the diaphragm. There's been some study done about the expiratory braking applied by the diaphragm. Think about this when you exhale. So when you breathe in, that's obviously your diaphragm at work. You can think about that as just that mechanism we just talked about. But when you exhale normally or passively, you don't just go and just breathe all your air out. That's not how it works. When you exhale passively, it's nice and slow and controlled. This is one of the reasons we think about our IE ratio and that our expiratory time is a good bit longer than our inspiratory time. We don't think about that. It just happens. One of the reasons why it happens is this phenomenon known as expiratory braking or diaphragmatic braking. And what that does is when we exhale, the diaphragm doesn't just snap back up into place. Because here's what would happen if that was true. If the diaphragm just snapped back up into place right where it was in its starting position, then what would happen would be we would lose all of our recruitment, all of those alveoli which maintain our functional residual capacity. We're going to talk about that in a minute as another thing maybe that you haven't thought a whole lot about since school. But if our diaphragm just snapped back up into its starting position, we would push every bit of air out of our respiratory reserve, what we think about as our reserve, or our functional residual capacity. If we did that, we would lose all our recruitment and have to get that all back every single time. The reason why this is important to you is because when you have a patient who is intubated and you're ventilating them, if you ventilate them with no PEEP, then essentially you're allowing the diaphragm to snap back up into position every single time because it can't duplicate, it can't mimic that braking action that it normally has. And that's the real big reason why we add PEEP on the ventilator or the bag valve mask or whatever we're using, is to counteract that process. We're going to talk in a later video about physiologic PEEP and how that's not really a thing. And this is really the beginning of that discussion. We think about why we put PEEP on mechanical ventilation, whether that's manual or through a ventilator. It's to preserve both functions of the diaphragm. So, coming up a little bit, we look at the upper airway. Now, you've probably talked a million times, a million different ways about what the upper airway looks like, why it's shaped the way it is, what it does, all the structures up there. The ones I really want to bring to your attention today are the nasal turbinates, these little spots right up here in your nose. When you think about your nose, which nobody ever does, when you think about your nose, remember that your nose doesn't go this way, it goes this way, straight back. And so when you take a big deep breath in, then the air swirls around these turbinates. I've got an MRI picture of your turbinates. And what you see here is all these little crevices and spaces that the air moves through when you inhale. The reason why that's important is because all those spaces are covered with these little fine hair known as cilia, and they're incredibly vascular, okay, super vascularly rich area, which lends a lot of moisture and warmth to your nasal passage, giving us the idea that when we inhale through our nose, we moisten, humidify, and filter the air. Now, why that's important to me and you as clinicians is that when we intubate somebody, we take all that function away. We bypass their nose completely. And now we're just ventilating them with air that's going through a straight, smooth tube with none of these features. And so this gives us probably one of the first things that you should have thought about in anatomy class that you probably were never taught. And that's the idea of the isothermic saturation boundary. This is the spot in the body, and it's usually about 5 centimeters below the carina. And what happens at the isothermic saturation boundary is by the time that the air that you breathe from the outside reaches that area, it's about the area of that green line right there, then it's going to be heated up to what we call BTPS. You've probably seen BTPS stamped on like some of your blood gas measurements or some gas readings or some things like that. And that's just a way that we quantify the amount of humidity and temperature in a gas, in this case, air or oxygen. And what BTPS stands for is body temperature pressure saturated. So when air is BTPS, body temperature pressure saturated, then it is assumed to be 37 degrees Celsius, body temperature, and saturated to 47 millimeters of mercury of water vapor pressure. The easy way to think about that is 100% relative humidity to the rest of your body. So when we breathe air in, by the time it reaches this ISB, then air should be at BTPS, 37 degrees, 100% relative humidity. Here's why this is important. Because if it's not heated to that temperature and humidified to that level of humidity, then your body has to do it. And so essentially everything above that line is a heat moisture exchanger. What that means for you as a clinician and what that means for your patient is that if the air isn't properly conditioned by the time it reaches there, they have to expend energy to physically heat the air and to humidify it so that the body can use it properly. We know our sick patients probably don't have that kind of calorie budget to work with. So one of the ways that we can help them, the way that we help them in the hospital, is that when they're on the ventilator for any length of time, or they're on high-flow nasal cannula, then we are going to give them heated, humidified gas. So they're going to have those humidifiers stuck on the side of the ventilator or stuck on the side of the high-flow nasal cannula, which is going to elevate the temperature to 37 degrees, and it's going to humidify it to 100% relative humidity before it ever gets to them. Now, in most cases, when we're out there on the ambulance or the aircraft, we don't have that. We don't have a humidifier like that. But what you can have is a little gadget called a heat moisture exchanger. And that's what you see here on the left side. And that's a simple little filter-like device. Some of them have HEPA filters built into them. And it goes right at the airway. And what it does is it captures the moisture and the heat of the exhaled air, and it applies it to the next breath in. So elevating that heat and relative humidity for the next breath on the way in. It's not as good as the heated humidity like you see there on the other side, but it goes a long way to helping to keep that isothermic saturation boundary where it's supposed to be, so the patient has to expend less energy to heat and humidify their gas. Now, surely by now, that at least in practice, if not in real life, you've seen a set of vocal cords before. You know what they do, you know how they work. But we're going to talk about them some way different right now. So chances are you were probably also told in your career that the epiglottis, up there you see at the top, is what keeps food and goo and stuff out of your airway when you're not breathing. And that just isn't true. Your epiglottis is a pretty decent, like, second string goalie. It's going to kind of bump stuff out of the way, but it's not a very good super stopping mechanism for keeping foreign bodies out of the airway. The best thing for doing that, and what really works for that, is the vocal cords. So whenever you're eating or drinking or doing whatever that is not breathing, then your epiglottis is going to flop down and your vocal cords are going to close. And by doing that, that 100% keeps everything out of there. That's why if you're drinking something and you try to talk at the same time or you start laughing, then those vocal cords open and that allows you to aspirate that. And, that's not fun for anybody. But the important thing for this for you is the function of the vocal cords when it comes to coughing. So we think about coughing kind of as a nuisance and an annoyance, whether we're talking about us or we're talking about our patient. If we can't get our patients comfortable on the ventilator, they may cough or start making faces and stuff. And that's annoying. It looks like it's uncomfortable for them. But the important thing to remember is that, and we can look at a cough, and I'm not going to just beat it to death here, but when it comes to a cough, there are actually 4 phases to a cough. So first is irritation. Something has to make you want to cough. So if you have a tube down your throat, that's going to make you want to cough. Smoke, foreign bodies, anything like that. After that, your body goes through a mechanism to help you cough, to help you get rid of whatever that thing is. So the first thing you have to do is inhale this big breath, what we call a vital capacity breath. And that's where you're inhaling this super large volume of air. What it's going to do is inflate and recruit as many alveoli as you can, get behind whatever that irritant is, hopefully, and allow you to force it out. But in order for you to force it out, you have to compress. Basically what you're doing then is when you build a really big cough, and you've experienced this before, I'm sure, is when you build a really big cough, as you get ready to blow that air out, you first are forcing air out against a closed glottis. Your vocal cords are closed, and you're pushing air up against the backside of your vocal cords. That's allowing you to compress that and really, really drive pressure behind that exhalation when you cough. And the last thing for the 4th stage, of course, is expulsion. You're actually doing the cough. So if you're thinking about what I just said, then you know that if your patient is intubated, you have a tube between the vocal cords. They can't close the vocal cords, therefore they can't actually cough. They can try, and you've seen them, on the ventilator before, on the stretcher. You get a high pressure alarm on the ventilator, and you look back, and the patient's doing like this, and you're like, oh, they're coughing. They're trying. And so this is what brings us to this really, really wonderful word that is everybody knows but nobody wants to think about. And that's pulmonary toilet. Pulmonary toilet is how well we can get the goo out of somebody's airway, upper and lower airways. The best way we can do that for somebody who is intubated is with suction. We can help them to cough. We can get them to cough this stuff out. There are machines that we can use for patients who are chronically trached, and they're called cough assist, really imaginative name. They're called cough assist, which help them to get a really big breath in and then help them to physically pull the air out. For our patients short-term who are intubated during a transport, then we need to be really, really prepared to suction them. The best way to suction them efficiently is with an inline suction like you see up here. A lot of values and a lot of benefits to the inline suction. You don't have to set it up every single time you want to use it. The biggest value by far is it stays sterile. As long as the tip of the suction catheter doesn't come out of the airway, like you don't disconnect it and wave it around or touch it, then it's going to stay sterile, or as sterile as it was when you got it. And you keep it inside that little sheath. You can run it down the tube and suction that stuff out. You also have to break the circuit less, which is going to maintain some of your recruitment, but the biggest thing there again is you're keeping foreign bodies and irritants and bacteria and stuff out of the airway. So helping our patients cough and helping our patients get the stuff out, combined with good heat-moisture exchange, are two huge keys to long-term respiratory health that we can contribute to even during a very short transport. Now, moving on down, next thing I want to pay attention to when you look at this picture, as you can see, on this patient's right side, we have the pulmonary, the bronchial system has been cast with wax. And that's where the air passages are. And on the left patient's left side, you see that we have the bronchial system is cast in addition to the pulmonary artery and the pulmonary vein. So you can see all the way down into the capillaries and where all the anatomy is. And the reason why I bring this picture up, besides the fact I think it's cool, is the idea of ventilation perfusion matching. And the realization, again, if you don't know it, you probably do, but it's really worth thinking about, is that sometimes you cannot fix an oxygenation or a ventilation problem with the ventilator alone. And that's because the ventilation and perfusion system in the lungs is so closely matched that both of those have to be addressed. So closely matched, in fact, that we think about like normal cardiac output. So normal cardiac output is stroke volume times heart rate. Normal cardiac output is about 5 liters a minute, give or take. Minute ventilation, that's how much air we move in and out in a minute. So it's your respiratory rate times your tidal volume. A very similar measurement to your cardiac output. In fact, so similar that normal minute ventilation is somewhere between 4 and 6 liters per minute. Very similar to cardiac output. So you can measure these things almost 1-to-1. Now they're typically measured at it's like 4 to 5 or 0.8 to 1. So it's typically the ratio is thought to be 0.8. But for my money, the easy way to think about it and the way to really think about what's important in your head is think of them as 1-to-1. So if we are ventilating more than we're perfusing, then you're going to end up with some dead space. You're going to have some area which is ventilated with no blood flow. If you're perfusing more than you're ventilated, you're going to end up with a big old intrapulmonary shunt. And either of those things are going to equate to problems with ventilation and oxygenation. Now, you can only fix so much of that with a ventilator and so much of that with respiratory care. Some of that you have to deal with improving cardiac output or managing fluid overload, all those kind of things. So as you go forward thinking about the ventilator, understand that, and we'll get into this into a later video, about how therapeutic a ventilator really isn't. How it's really kind of buying you time while you figure out what the real problem is. This is one of those things. Once you've optimized your ventilator settings, you've got them as oxygenated and ventilated as you possibly can, you may have to do other things to further improve their oxygenation and ventilation outside of the ventilator. So now let's travel our way on down the bronchial tree. And once we get out of the bronchial dead space, where there's no gas exchange taking place, then we get down to this thing, the thing we always think about, and that's the alveoli. So of course the alveoli is where the air ends up and where those thin walls meet up with the capillaries and allow for gas exchange. Now one of the things I always like to point out here when we're talking about the alveoli and the capillary is that little membrane in between, the alveolar capillary membrane. And it is my bet that if you can't oxygenate somebody despite your best efforts, chances are the alveolar capillary membrane is to blame. it's either gotten wide or it's got some fluid in it or there's some kind of pressure built up that will not allow gas to exchange. And it's almost always oxygen, which is your problem. CO2 tends to exchange really, really easily. Oxygen you tend to have a bigger problem with. But even this picture doesn't tell the whole story. And this picture isn't complete. So if we look at this other picture, we see kind of a side view. And so in that first picture you saw there was a single alveoli and a single capillary. In this picture you see where there's like 3 or 4 capillaries wrapped around this alveoli. That still doesn't tell the whole picture. So I tend to think about this more like, and I'm not the first one to think about or to describe alveoli as grapes. And so when you think about how many alveoli you have in your body, the average adult person has about 600 million alveoli. And these are part of a very, very complex network. Of course, kind of like you see in the grape picture here, they're at the end of the terminal respiratory bronchioles. So they're connected that way and they ventilate that way. The alveoli are also connected to one another. So through these little holes we call pores of Kohn. And that allows gas to exchange from one alveoli to the other. But you see here on this picture, I've got some spider webs wrapped around the alveoli. And this is the big thing I want you to grab hold of in terms of alveolar recruitment and surface area. Is that, so somewhere between 350 million and 600 million alveoli in the average human adult. For each one of those alveoli, there can be up to 1,000 capillary interactions. So it's not one capillary to each alveoli, it's not 5 capillary to each alveoli, it's up to 1,000 capillary to each alveoli. What that means for you, and we actually have a picture, this is an electron microscope picture of a single alveoli, one. And you can see here, just to give you some context, the blue part there, that is the alveolar wall. The yellow things, those are alveolar macrophages. All those red things are capillaries. No surprise there. The individual little blobs inside of those capillaries are erythrocytes. That's how big these capillaries are. They are one red blood cell wide. And there are 1,000 of them, potentially, touching each alveoli. What this means for you is when we talk about ventilating somebody, and even oxygenating somebody, you're going to hear the word recruitment over and over and over again. And the important thing about recruitment is surface area. The more surface area that you engage, the more gas exchange you can have. Because if you think about each one of those alveoli touching 1,000 more capillaries, that's 1,000 times more, potentially, gas exchange you can have than if you didn't recruit that alveoli. So when we talk about patients with severe lung disease, acute or chronic, we spend so much time talking about how do we recruit more good lung? How do we perfuse more good lung? This is what you're talking about. This is the literal rubber meeting the road, is recruiting alveoli and capillaries and putting them together. Now, remember, all the stuff we've talked about so far is designed to be run by a person all by themselves. They don't need us at all until they get sick. And what you see here, this is a graph of spontaneous breathing pressures. So here we see some lung volume at the top there, and then we see alveolar pressure and pleural pressure. And I want you to pay attention to the one in the middle, the alveolar pressure. If you look on your right side under number 2, that's alveolar pressure in spontaneous respirations. Now remember, spontaneous respiration is negative pressure. So when you breathe in, the intrathoracic pressure is going to be negative until you stop that breath. If you stop it and hold it, then the pressure inside is going to be momentarily positive until you breathe out again. Usually the highest that pressure is going to reach is like 3 or 4 centimeters of water. And then when we exhale, as we start pushing out and that pressure gradient changes, then the pressure is going to go up again to 3 or 4. But usually when we inhale, it's going to be negative. Compare that to positive pressure ventilation. And think about how high we are willing to let peak inspiratory pressures get before we get terribly excited, especially in super sick patients. So, if we see peak inspiratory pressures of 30, then if somebody is really, really sick and not oxygenating well, then we may be willing to tolerate that for a while if that's what it takes to oxygenate them. But understand that a peak inspiratory pressure of 30 is 10 times what that pressure is normally under negative pressure ventilation. So I've said this before, and I will say this many times throughout this series, there is nothing therapeutic or anatomically respectful about mechanical ventilation. Your body doesn't like it. It's not meant to like it, based on just this idea of negative pressure breathing. And so one of the things we always think about, and I describe this in a what I think is an interesting way, of how people are supposed to work. In other words, how the human body is supposed to work at a very basic level. And I describe this in what we call the earthling rules. So the earthling rules there's 5 things which go into this. And what these are 5 things that people, specifically bipeds who live on Earth, have to do to thrive. The very first thing we have to do is walk upright. We are meant to be upright. Almost everything we do in life is better if we are moving. You've probably heard the thing, it's not new anymore, but they say sitting is the new smoking, because being sedentary is that detrimental to our health. Well, you can look at that even further by thinking about how much we need to be up moving around, and how there are so many things now for which we are not positioning our patients flat. Probably one of the better examples that I think of is, somewhere in the world, a little old lady is going to break her hip this morning. By this afternoon, after her surgery, they're going to have her up walking, because it is that important for her to be upright and mobile. One of the other favorite things that I have, that I heard not long ago, was said, if you take a man who is not sick and you confine him to bed for 7 days, he will be. It is just not normal for us and not okay for us to lay flat all the time and not move. So the first earthing rule is we have to get up and move. We have to walk upright. Rule number 2 and number 3 is we eat our food and drink our fluid. You can absolutely nourish and hydrate someone parenterally. You can do it through IVs and even through gastric tubes and things like that. But it's not the way our body's meant to work. Fluids and food are meant to contact every piece of our digestive system, because every piece does a different job. If we provide nutrition to somebody through like TPN for any length of time, then their digestive system and their endocrine system are going to suffer, because they're not working the way they're meant to. But the 2 that we are really concerned about here are, we are meant to breathe as earthlings atmospheric concentrations of oxygen at negative pressure. So when we are just walking around just doing what we do, we are breathing negative pressure ventilation at regular room air. What we think of room air: 21% oxygen, 79% nitrogen, and all the little trace elements. If we deviate from any of these 5 things for any length of time, our health will suffer. Now, there are people in the hospital today, right now, who are breaking all 5 of these rules, and that's what it takes to keep them alive. But my advice to all people who are new to the ventilator when they come in is, one of the things that we like to do, we can't do a whole lot about the first 3 because we're transporting somebody. We're not going to feed them. We're not going to give them anything to drink. But we can get them as close to room air and get them as close to negative pressure ventilation as we possibly can within our transport and within the first hours and days in the hospital, trying to adhere to these earthling rules. The other thing I want to think about in terms of A&P, and specifically physiology in this case, is our lung volumes and capacities. So here you see a lung volume chart, and just for simple definition, so a lung volume is a single volume. So like tidal volume, that's the amount of air you breathe in and breathe out. Anytime you have a capacity, that is 2 or more volumes added together. So the 2 that I want to pay attention to here, that we're going to talk about a lot as we go forward, are tidal volume and functional residual capacity, or FRC. Tidal volume is going to be the biggest contributor to minute ventilation, and that's how we're going to ventilate. That's how we're going to move CO2. Functional residual capacity, or FRC, that is the air that's left at the end of a normal tidal volume exhalation. And that's what's going to define our oxygenation. So when we put somebody on PEEP through the ventilator, we put somebody on CPAP, or the EPAP part of non-invasive ventilation, that's trying to maintain our FRC, and that's what's going to help us to oxygenate in the long term. When you hear people who are grunting, or like patients with COPD breathing through pursed lips, what they're trying to do is generate or maintain their FRC. So speaking of how we oxygenate, and how we ventilate, we want to talk about these 4 terms in context. So when we use the word ventilation, what we mean is the movement of air, plain and simple. Now for our purposes, when it comes to the ventilator, it's the movement of CO2. It's moving CO2, it's getting CO2 out of the lungs. Oxygenation is supplying the body, blood, tissues, and cells with oxygen. So it's actually oxygen delivery. And I'm going to come back to oxygen delivery because obviously it's important. Respiration is simple gas exchange. So when we breathe, we are respirating with the outside air. That's pulmonary respiration. Way down in our big toe, our cells are respirating with the capillaries around them, exchanging gas across the cell membrane and across the alveolar or the capillary wall. That's cellular respiration. So when we exchange gas, then that's what we're doing. So a lot of people use these words interchangeably. That's not okay. We're going to talk about that in a second. The last one up here is diffusion. Diffusion is the simple movement of gas from a higher partial pressure to a lower partial pressure. And why that's important is because almost everything we do in respiratory care is designed to augment and make diffusion better. Most people, like me and you sitting here right now, if left alone and we're reasonably healthy, we will diffuse gas exactly like we're supposed to without any problem. And when people get sick is we have to do things to help them diffuse gas, like helping them to ventilate, helping them to oxygenate. Speaking of oxygenation, I wanted to come back to this for a second. I'm going to spoil a little surprise for you here and to tell you that every single person in medicine, whether you are a flight paramedic, whether you're a flight nurse, whether you're a plastic surgeon, whether you're a nursing assistant, your job is to deliver oxygen to tissues. That's what we do. There's all kinds of other stuff that goes on. There are things which are peripheral to that. But what you do with a ventilator, what you do with an oxygen mask, what you do with a helicopter is you deliver oxygen to tissues. If we don't do that one job, then none of the rest of our job really matters. So, speaking of the difference between oxygenation and ventilation and respiration, can we really think about those things the same way? And the answer is absolutely not. So you can see the definitions are different, but the clinical applications are also very different. So, and we get our guidance for this from a pretty strange place, is the evidence-based guidelines for determining brain death. And the reason why this is a good place, albeit it sounds like a strange one, to think about how we ventilate and how we oxygenate live people, is because this is a basic lesson in how it's done. So one of the ways they determine brain death in adults is through a CO2 challenge. And the first thing to do there, since they have a patient who is obviously not triggering the ventilator on their own, or else they wouldn't think they were brain dead, they disconnect the ventilator, they just take it off. And when they do that, then obviously the patient's not being ventilated at all. But to make sure that they still get some oxygen, they're just going to take a regular old piece of oxygen tubing, and sometimes they'll use like a suction catheter, and they'll just run it down the ET tube all the way to the level of the carina, and it'll just sit there. And they're going to run the oxygen flow at 6 liters a minute under no pressure. And it's just going to run like that. And typically what they're going to do is when they first start, they're going to draw blood gas, and they're looking for a normal CO2. So if you got them on the ventilator, and the ventilator is set correctly, the CO2 should be normal. And then they're going to wait, and they're going to wait for like 15 minutes. And then in 15 minutes, they're going to recheck a blood gas. And what should happen during that time, if the patient hasn't breathed at all, which they're not going to, then the CO2 should have gone up from whatever normal was. We'll say a stone normal of 40. It should have gone up by like 20. So we'll say to 60. By the time it goes up to 60, then the brain should stimulate that patient to breathe. If it doesn't, then that is one of the clinical determinants of brain death. Now, the reason why we talk about this in this particular context is because during that whole time, during 15 minutes of no breathing, zero breathing, the patient's oxygen saturations are 100% because we are providing them passive oxygenation. So the important part here is that you can oxygenate without ventilating, you can ventilate without oxygenating. Those two things are entirely separate. And that lesson is also true for the patients that we're taking care of just under normal circumstances. So with that said, that brings us to the 3 most important rules of respiratory physiology. Rule number 1, we ventilate patients, or we ventilate ourselves with minute ventilation. So when we think about ventilation, remember ventilating is moving CO2. So the way that we move CO2, either as independent humans following the Earthling rules or as clinicians doing it for somebody else, we ventilate CO2 with minute ventilation. Minute ventilation is tidal volume times respiratory rate. Tidal volume is just the air you breathe in and out in a single breath. Respiratory rate, self-explanatory. So if you want to fix a CO2 problem, in other words, you want to ventilate more, you either adjust the tidal volume or you adjust the respiratory rate. It is simple as that. Now, typically, once we set the tidal volume at somewhere like 6 to 8 milliliters per kilogram, we're usually going to leave that alone. That's usually going to be okay. There are going to be times where we want to change that, but that is not usually our first move. Once we get our tidal volume physiologically tuned, then we're going to make those changes with respiratory rate. And the reason why we say it that way is because being mindful of the tidal volume is always important, because there are going to be some times where you may encounter a patient who has an incorrectly set tidal volume, and you have to change both things to maintain or to gain the proper minute ventilation. Now, if the minute ventilation, or the tidal volume rather, is not optimized, you have to fix that first. The reason for that is because tidal volume is going to make a bigger difference than respiratory rate. And this goes back to the idea of alveolar recruitment and dead space ventilation. So our dead space, our physiologic dead space, is typically fixed. And we'll get into that in a later video. So once we have ventilated all the dead space, everything that comes after that is alveolar volume. Every drop of tidal volume you add after that is going to be alveolar volume, which means it's going to contribute to gas exchange. So if you encounter a patient whose tidal volume is not correct, it's too small, then you have to fix that first to correct their minute ventilation, then you can correct their rate. Maybe the most important thing on this slide, though, is there at the bottom, and it says, whatever you do in this case will not significantly alter oxygenation. You cannot ventilate your way out of an oxygenation problem. You have to deal with that differently. So let's take a bit deeper dive into this rule. So CO2 production, what our cells generate at rest, is about 200 milliliters a minute. And when you apply some fancy math to that, and we assume a normal minute ventilation of, say, 4 liters per minute, then that's going to give us a PCO2 of about 40 millimeters of mercury. So always keep that in mind, 200, 4, and 40. So if we produce the normal amount of CO2 and we ventilate with the normal amount of minute ventilation, then that's going to maintain our PCO2 of 40. So we think about somebody who is exercising. Say, take a healthy person who's out there running. Or you see those athletes who are on the treadmill and they've got all the apparatus hooked up to them and they're taking all kinds of charts and measurements and things like that. During that exercise, if you were to capture a PCO2 from them, which I'm sure they do, what you would find would be a normal PCO2, because when they exercise, their CO2 production goes up, but their minute ventilation also goes up. And so if you keep those things in balance, then that's going to keep the PCO2 right where it's supposed to be. Where you get into trouble is folks who are in respiratory failure. So take somebody who has like COPD, for example, and they have chronic respiratory failure, and they exert themselves for whatever reason. Then what happens is now you get what they call acute on chronic respiratory failure, where now that patient has exceeded his normal limits of ventilation. He's also exceeded his normal metabolic compensation for his high CO2. And so what happens is you have CO2 production that goes up, minute ventilation which can't compensate, and therefore PCO2 goes up in equal measure. And those patients, obviously getting extremists, have to be intubated and ventilated. Somebody who hyperventilates, that's somebody whose minute ventilation exceeds normal, 4 liters a minute in this case, but their CO2 production hasn't gone up. And so in that case, their CO2, the PCO2, is going to drop. You look at temperature derangements, you see the same thing. If somebody is hypothermic, then their CO2 production is going to drop. Their minute ventilation may stay the same, and their PCO2 is going to fall. Then the opposite would be true in hyperthermia. This is all about balance, and this is really what we're aiming for when we are whether we're trying to ventilate somebody or they're trying to ventilate themselves, is keeping within these parameters: the CO2 production, the minute ventilation, and then the resultant PCO2. So you've been faced with, I'm sure, the idea of correcting a CO2 which is out of range. And the first thing I'm going to say right here, just as a lead-in for something we're going to talk about in a later volume, is that if you're talking about end-tidal CO2, and end-tidal CO2 is the CO2 measurement we almost always have access to. You may not always have access to a blood gas, either be able to do one yourself or have access to a recent one, but you almost always have access to end-tidal CO2 for an intubated patient. And so when we think about this, if your end-tidal CO2 is high, so like say it's 50 in this case, or 60 or 70, then we know our PCO2 is also at least that high. And so you can feel confident making some ventilator changes based on the end-tidal CO2. If your end-tidal CO2 is low, let's say it's 20, you really have no idea what their PCO2 is if you don't have a recent gas. So you have to be very, very careful about making ventilator changes based on a low end-tidal CO2, because you may have a VQ mismatch. You may have a really underperfused patient or something like that, and that's just dangerous territory to be in. And again, we're going to talk about that in later videos. But in this case, we're going to talk about a high end-tidal CO2, or a high PCO2 for that matter, and how we can correct that without just guessing. And so many times somebody will say, okay, in this case, you'll see our end-tidal CO2 is 50, and we have a rate of 12 and a tidal volume of 500. And somebody say, okay, our CO2 is 50, we want it to be normal, we'll say 40, and so we're just going to increase the rate by 2, or increase the rate by 4. We're just going to pick a number out of thin air. And that's not really the way to do that, because there is an evidence-based mathematical way to do that. There is a linear relationship between minute ventilation and your CO2. Now, this formula was meant to work, and it works with PCO2. But as long as you have a reasonable expectation these things correlate, then you can also think about this in terms of end-tidal CO2. So our example here is we have an end-tidal CO2 of 50, tidal volume of 500, rate of 12. So first thing we want to do is know what our minute ventilation is. In this case, we know our minute ventilation is our tidal volume times our respiratory rate. So 500, or 0.5, times 12 will give us 6 liters a minute. So we see our CO2 is 50. We want that to be normal. So we're going to say I want our CO2 to be 40. So we're going to divide our CO2 currently by our desired CO2. So we're going to take 50, divide by 40, and that's going to give us 1.25. And what that number is telling you is that we're going to increase our minute ventilation by 25%. Again, that linear relationship. So we're going to take our minute ventilation of 6,000, 6 liters, multiply it times 1.25, and that's going to give us a minute ventilation of 7.5 liters, or 7,500 milliliters. Now we're going to assume, for this example, that our tidal volume of 500 is physiologically appropriate. So we don't want to change that. So if we're not going to change that, that means we're going to have to change the rate. So how do we find out what our new rate's going to be? The way we do that is take our new minute ventilation, in this case 7,500, and we're going to divide that by our tidal volume, which is 500 milliliters. You divide 7,500 by 500, and that gives you a new respiratory rate of 15 breaths per minute, which should, over the span of a minute or so, bring our CO2 from 50 down to 40. So you don't really have to guess at this. You can have a really, really solid ballpark calculation about what our respiration or what our minute ventilation needs to be to give us the CO2 that we want. Rule number 2 is we manipulate oxygenation with FiO2 and mean airway pressure. FiO2 is by far the easiest way to do this, it's the fastest way to do this, and it's the one that's probably going to make the biggest difference in the short term. Short term is the key here. So that first little piece of math you see up there is the alveolar gas equation. This, again, probably something that got left out of your nursing or paramedic school. I didn't learn about it until I went to respiratory school. But we refer to it as P big AO2. So typically when you see like arterial partial pressure of oxygen, that's P with a lowercase a, P with a capital A, or P big AO2, is alveolar oxygen concentration. And the calculation for this is PB, which is barometric pressure, minus water vapor pressure, multiplied times your FiO2 as a decimal, and you're going to subtract from that the PCO2 divided by the respiratory quotient. Now we're going to talk about all this stuff by itself. So the barometric pressure is just exactly what it sounds like. It's the barometric pressure in millimeters of mercury wherever you are. I happen to live at sea level, so that's what we're going to talk about. Normal sea level barometric pressure is 760 millimeters of mercury. The water vapor pressure is the same as we talked about earlier when we talked about body pressure, temperature, saturated. So we said that air, gas on the inside that we can use is heated to 37 degrees and it's humidified to a water vapor pressure of 47 millimeters of mercury. So that's the number we're going to use here. So we're going to subtract 47 from 760, which is going to give us 713. And the first example we're going to do here is with room air. So room air FiO2 is 21% or 0.21. And so when you multiply those together, you get like 149 and some change. From that, we're going to subtract our PCO2, which we're going to assume is going to be 40, divided by our respiratory quotient. Respiratory quotient is almost always thought of as a constant at 0.8, but all it is your CO2 production per minute divided by your oxygen consumption per minute. So CO2 production per minute is 200 milliliters. Your oxygen consumption per minute is about 250 milliliters. You divide 200 by 250, that gives you your 0.8, and that's typically what we go with for this. So we're going to divide 40 by 0.8, which is going to give us 50. So if we take 149 minus 50, that's going to give us 99.7. Again, ballpark. Now this number is interesting because whenever you're learning all your normal lab values, like your normal blood gases, one of the things you're going to learn is a normal PO2, arterial partial pressure of oxygen. You're going to learn that number is usually about 100. That's where this number comes from, is when oxygen is present in the alveoli, it is assumed that all of that oxygen is going to diffuse over to the capillaries and become capillary oxygen content, which turns into your PO2. So when we see normal PO2 on room air, what we're thinking about then is 99, 100, somewhere in that neighborhood. So that's where the normal PO2 comes from. The other two examples up here are on 50 and 100% FiO2. And the reason why we show these, not to go through the math again, but you see on 50% FiO2, your PaO2 goes up from 99 to 300. And on 100% FiO2, it goes up from 99 to 663 millimeters of mercury. If you add FiO2, you're going to see dramatic increases in the amount of oxygen available in the alveoli. And this is important for a couple of reasons. First of all, if you need to increase somebody's oxygen saturation or increase somebody's oxygenation quickly, rapidly, there is no better way to do it than FiO2, unless FiO2 doesn't work. If you turn up their oxygen 100% and they're still not oxygenating, what this is telling you is they have an enormous shunt. And you have to do something else to fix that, which is going to be the second thing we're going to talk about, which is adding mean airway pressure. The other thing about this too, we're going to get into this in later videos, and why this is so important, is if you have a patient who is on 100% oxygen, through a ventilator, through a back valve mask, whatever, if they're on 100% oxygen and they are not 100% saturated, that is a big problem, because you have provided them with plenty of oxygen to their alveoli, and for some reason they're not using it. Excuse me. So that is a big tip to look at. If you have somebody on 100% oxygen and they're not satting 100%, that's a big red flag that you got a really sick patient. So the other part of oxygenation is mean airway pressure. Excuse me. So mean airway pressure is a pretty easy thing to grab hold of, and I always like to think about it in terms of mean arterial pressure. And a lot of people can grasp mean arterial pressure even if you don't remember what the equation is by thinking about the word mean. Mean typically means average. So mean arterial pressure and just not going to give you PTSD by bringing this up, but mean arterial pressure, the way you calculate that is take your diastolic pressure, you multiply it times 2, and then add that to your systolic pressure, and then divide whatever that number is by 3. The reason why you multiply your diastolic pressure times 2 is because you are in diastole twice as long, theoretically, as you are in systole. And so that gives you your mean, how much pressure is present on the inside of the vessel, specifically the aorta, at any given time. Okay? When you calculate mean airway pressure, you're doing the same thing, except we know all of these numbers. We can calculate the time and the pressure at any given time. So instead of just taking a constant like 2, we calculate using those times. So if you look at the equation here, we have TI, which is inspiratory time. That's how long it takes to get the breath in, times your peak inspiratory pressure. That makes perfect sense. Inspiratory pressure times inspiratory time. You add that to expiratory pressure times expiratory time. And then you divide that whole thing by your inspiratory time and expiratory time added together, what we call the total cycle time or respiratory cycle time. Now this is a lot of numbers, and this only works in pressure control ventilation when you're controlling all these things. But I'm going to tell you a little secret, and this is the key to understanding this and why this matters, is whatever change you make to the PEEP. So chances are, if you looked at this and you don't know any of these other numbers, when you look at PEEP, you know that number. You know what PEEP is. You at least have some passing idea of what the definition of PEEP is. For every 1 millimeter of mercury change you make in PEEP, you're going to make about that same change in mean airway pressure. So if you have somebody who has on a PEEP of 6, let's say, and the ventilator tells you their mean airway pressure is 10, if you turn their PEEP up to 8, then their mean airway pressure is probably going to go to 12. That's the easiest way to grab hold of this and understand the change that you're making. In the graph that we have here at the bottom, we see again our lung volumes, and the area that is shaded in green is your FRC, your functional residual capacity. When you're adding mean airway pressure, when you're adding PEEP, when you're adding CPAP, what you're doing is you're increasing your FRC. Little secret about CPAP too, we're going to talk about this in a later video, but cool thing about CPAP is your CPAP is continuous positive airway pressure. It's always the same pressure. Therefore, if you have somebody on a CPAP of 10, their mean airway pressure is 10 because that pressure never changes. So that's a little tip to take with you. And finally, rule number 3 for the most important rules of respiratory physiology is your respiratory drive is most responsive to pH changes, not just CO2. So your central chemoreceptors up in your brainstem are very sensitive to changes in the pH of your cerebral spinal fluid. Your cerebral spinal fluid, by extension, is very sensitive to changes in your blood pH. Therefore, when your cerebral spinal fluid pH changes through an acidosis or alkalosis, regardless of the source, then your brain is going to respond to that. And this is why you may have patients who have CO2s of 6, but have a profound metabolic acidosis who are breathing 40 times a minute. Because your respiratory drive is not responding to that CO2, it's responding to acid, whatever that acid source is. What this means for you clinically, and something that is, I'm sure is not new, is that when you have those patients who are in a profound respiratory acid, or metabolic acidosis rather, like somebody in DKA. DKA is probably the best example of this. Is you're going to encounter that patient and they're going to be breathing 40 times a minute, super breath, super fast and super deep. They're moving, 11, 12, 13 liters a minute ventilation. And if you were to draw a gas, you would see their CO2 or their pH is 7.01 and their CO2 is 4. Well, obviously CO2 is not making them breathe fast. Their pH is. The important part about them is that you have to maintain that level of minute ventilation and that level of respiratory compensation or they will die. And one of the biggest mistakes people make is they'll try to get those patients to a normal CO2 when CO2 is not their problem. It's whatever is making them breathe fast like that, whatever is dropping their pH. So, a recap for Volume 1. Understanding the A&P, especially this part of the A&P that we just talked about, is crucial for understanding the respiratory care that you can provide. Whether that's going to be a couple liters by nasal cannula or whether that's going to be on a high-frequency ventilator. Understanding how this ventilation is going to work and how this air is going to move throughout the respiratory anatomy is so important for you to understand how things work. The reason why we use most respiratory and ventilation adjuncts are to replace or mimic anatomical function. It's not for therapy. It's not to make them better. It's just to replace or bridge that particular function until that patient can get better. Remember, high pressure or basically any positive pressure ventilation is incredibly offensive to the body and we don't like it. And if you follow the 3 rules, ventilate with minute ventilation, oxygenate with FiO2 and mean airway pressure, and remember that CO2 or that your pH is really what's driving that patient to breathe. If you follow the 3 rules, you're going to be in really good shape. Again, my name is Michael. Thanks for watching, and I'll see you the next time.